Hello, I'm Dr. Anil Gudi. I'm a consultant in reproductive medicine and assisted conception at Fertility Plus and the Homerton Fertility Center. So today I'm going to talk to you about a slightly different subject. We've used letrozole quite a lot. And what is its use in IVF? Now, the entire concept comes up by saying, well, if you add letrozole in IVF to gonadotrophins, does it increase oocyte yield? So this was a paper published in Gynecological Endocrinology in 2019. And where do we use letrozole generally? We use it when we are using it for breast cancer patients. So you're combining it with gonadotrophin so you keep estrogen levels low. And in some studies have shown that if you add letrozole to a gonadotrophin cycle, oocyte yield may increase. And so this study was to compare oocyte yield in women with breast cancer who had letrozole with other oncological problems with elective oocyte preservation. So control ovarian stimulation was performed with recombinant FSH, started on day 2 or day 3, antagonist protocol, and breast cancer or letrozole from the day of stimulation to trigger. Decapeptyl 0.2 was used as trigger, and egg collection was done 36 hours later. Mature oocytes or embryos were frozen, and before 2008, slow freezing was used, while after that, vitrification was used. So let's look at the letrozole and gonadotrophin and the rest. And if you have a look at it, the general number of oocytes or mature oocytes were similar in both the groups. So what do we know? We think that aromatase inhibitors prevent aromatization of androgens to estrogens, mainly in the granular cells, causing a resulting circulating estrogen to be low and a pituitary feedback. So it increases the gonadotrophins. But also what is very important with letrozole is that it causes accumulation of intraovarian, intrafollicular androgens in a maturing follicle. So this concept has generally been used. And it's believed that by increasing intraovarian androgens and intrafollicular androgens, you are making the follicle more sensitive to FSH stimulation. So where else do we use it? DHEA, giving testosterone supplementation before stimulation. The entire concept is that if you prime the follicle with androgens, then your response is likely to be better. Now, there were multiple studies done, and as usual, especially in poor responders, we have tried our best to see if we can improve follicular response. So in 2005, again, letrozole-treated patients had significantly higher levels of follicular androgens and a higher number of oocytes and higher implantation rates. In 2016, again, a higher number of oocytes was seen. In 2017, there was a study concluded that using letrozole improved the outcome in normal responders. Again, there have been studies which have shown no difference. So in this study, the BRCA carriers of breast cancer had the same ovarian response, and letrozole did not increase oocyte numbers. And the biological effect of aromatase inhibitors and increased intraovarian androgen levels in poor responders may be specific to that group and may not be across the board. But what does this start teaching us? It starts teaching us that if there's no difference, especially in some cases of poor responders, does it make sense in adding letrozole? So what you could tell patients is, yes, I don't think it may increase, but there could be a possibility that in some women, increasing the intraovarian androgens may make the follicles more sensitive to FSH stimulation. What is the evidence? We'll say both ways. The evidence seems to be either for or no difference. So why not give it a try in some cases? Now, one of the things which we also understand is that what does FSH do? It gives rise to pituitary FSH increase. So you are working with very much what we call as in older times a flare protocol. And what is the flare coming up from? A flare is coming up from letrozole, and letrozole is getting the pituitary to start increasing its FSH and its stimulation. So I think it's worth sometimes giving this a try and seeing whether that may help some of your patients. So anyway, that's it for today. If you have liked the talk, please do like the page, share it, and let your friends know, and let us start sharing evidence-based medicine. Thank you.